Hello everyone, welcome back. Today I'll be covering OSCE question and answer. Happy practice. 45-year-old male, a laborer, complained of numbness and weakness of his right ring and little finger. A. Describe the clinical picture of the hand. 2 marks. As illustrated. And the answer is, there is a metacarpophalangeal MCP hyperextension and proximal interphalangeal PIP and distal interphalangeal DIP flexion. It is a claw fingers of the ring and little finger. Describe the likely structure affected and pathophysiology of this condition. Is an ulnar nerve injury. When the ulnar nerve is injured, the muscles innervated by the nerve begin to weaken. This causes imbalance between the extrinsic and intrinsic muscles. Weakened intrinsic muscles leads to loss of metacarpophalangeal flexion and loss of interphalangeal IP extension. Strong extrinsic muscles will lead to an unopposed extension of the metacarpophalangeal joint. The flexor digitorum profundus and flexor digitorum superficialis muscles not innervated by the ulnar nerve remain strong and lead to unopposed flexion of the PIP and DIP joint. Where is the location of compression? The ulnar nerve can be entrapped at several sites. The cubital tunnel is the most common. The other sites are the medial intermuscular septum, the ulnar groove in the epicondylar region, and the deep flexor pronator aponeurosis. Entrapment in Guyon's canal results in ulnar tunnel syndrome. What is ulnar paradox? The higher the lesion of the ulnar nerve injury, the less prominent of the deformity and vice versa. There would be less severe claw hand deformity. There will still inability to flex the distal interphalangeal joint and weakness of the flexing metacarpophalangeal and proximal interphalangeal of digits the ring and little finger. Again, seen with higher nerve injuries. That means cubital tunnel syndrome, where there would be severe muscle impairment. Flexion at the proximal interphalangeal joint and distal interphalangeal joint not really present due to loss of flexor digitorum profundus action. Thus, proximal lesion appears less severe. That's why it became paradox. This figure will explain the ulnar paradox clearly. On your right hand side, the ulnar nerve injury at the elbow will cause less clawing. That's why it's called ulnar paradox. More because of more severe muscle impairment but less clawing. The flexor digitorum profundus is paralyzed. On the left-hand side, the ulnar nerve injury at the wrist causes more clawing. There will be more severe claw fingers. The lesion usually distal at the wrist joint or Guyon canal. The prominence of the claw fingers or interphalangeal flexion is due to unopposed flexor digitorum profundus. And additional notes. Ulnar nerve palsy can occur after injury to any portion of the ulnar nerve. The ulnar nerve is the terminal branch of the medial cord, C8, T1. The ulnar nerve innervates the flexor carpi ulnaris, FCU, and flexor digitorum profundus, FDP, after it passes through the cubital tunnel. The nerve provides sensation over the middle half of the fourth finger and the entire fifth finger and the ulnar portion of the dorsal aspect of the hand. This figure illustrates the cause of the ulnar nerve at the arm. Again, arises from the medial cord of the brachial plexus. It runs medial to the brachial artery. Then later, it pierces the medial intermuscular septum around the middle of the humerus and continues down on top of the medial hip of the bicep brachii. Then later, it travels behind the medial epicondyle, where it becomes more superficial and it gives branch to the elbow joint. The next regarding the cause of the ulnar nerve in the forearm. Okay, after it gives branch at the elbow joint, it enters the forearm in between the head of flexor carpi ulnaris, in between the two heads. Then it gives branch. Then later come down, it also gives branch to the palmar cutaneous branch of the ulnar nerve midway along the forearm and travels under the antebrachial fascia directly above the ulnar artery. And this palmar cutaneous branch will pierce the antebrachial fascia in the distal third of the forearm and innervates the skin on the ulnar half of the palm. So ulnar nerve also travels in between the flexor carpi ulnaris and the flexor digitorum profundus. And it gives branch to ulnar 2 digits of the FDP. Then later, it travels down in the radial side of the flexor carpi ulnaris tendon. And it crosses under the flexor carpi ulnaris tendon together with the ulnar artery at the level of the wrist. And it passes between the hook of hamate and the pisiform in the Guyon canals. Then later enter the hand. Again, muscles innervated by the ulnar nerve include abductor digiti minimi, flexor digitorum profundus, flexor digiti minimi, opponens digiti minimi, ring finger lumbricals, small finger lumbricals, dorsal and palmar interosseous muscles, adductor pollicis, deep head of flexor pollicis brevis. I usually have this anonym LOAF, lumbricals, opponens, abductor, adductor, and flexor. Again, this figure shows the distribution of the motor branches of the ulnar nerve. Number 1, the flexor carpi ulnaris as FCU. Number 2, flexor digitorum profundus FDP, ulnar portion. Number 3, hypotenuse muscles, the abductor, short flexor, opponents of the little finger. Number 4, palmaris brevis. Number 5, all dorsal and palmar interossae. Number 6, ulnar lumbricals. Number 7, deep head of the flexor pollicis brevis, FPB. And number 8, adductor pollicis. The differential diagnosis of claw hand should include cervical radiculopathy, Dupuytren contracture, Klumpke paralysis, lower brachial flexopathy. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.